I welcome you all to today's webinar, and let me have the great pleasure of introducing Dr. Niranjan Chavan, our dear friend, Mumbai Secretary of the Secretary of MOGS, the biggest society of our Foxy. And he's the national coordinator for our committee, which is the chairperson is Komal Chavan. So Niranjan Chavan, he's a professor and unit chief at the Science Hospital. He's a national coordinator of the Foxy Medical Disorders in Pregnancy Committee 2019 to 21. We all know him as the chairperson of the Foxy Oncology Committee from 2012 to 14 and the present secretary of MOGS. The chair and convener of the Foxy Cell of Violence Against Doctors. He's the dean and chairman of the Academia of Global Obstetricians and Gynecologists. Chief editor, the AFG Times. He's a course coordinator of 11 batches of MUHS recognized certificate course of the BIMIE at LTMGH, member of managing committee of IAG. And in fact, Niranjan Chavan's CV will be enough for today's webinar. So proud privilege to introduce Niranjan Chavan.
Thank you, madam. So nice of you. We welcome our President Foxy 2021, the great Iron Lady of India, none other than Dr. Shanta Kumari. So we will be having her to give her presentation, but she doesn't require an introduction, but it is my duty to introduce her. She is also a consultant and a laparoscopic surgeon at Somajguda, Hyderabad. She has donned many hats, and I would like to enumerate them as chairperson Foxy ICOG 2018, secretary of ICOG from 15 to 17. She was also our Foxy vice president in 2013 and has been our IAG managing committee member from 2015 to 2019.
Thank you, Niranjan. Let's go to the...
Yes, madam. So I would also now request Dr. Suvarna Khadilkar, madam, to join with us. Dr. Suvarna Khadilkar is professor and head of the department in Bombay Institute of Medical Sciences, which is affiliated to MUHS. She is the treasurer of Foxy, treasurer of MOGS, and also treasurer of IMS. She was also the professor and head of the department in Government Medical College, Kolhapur, and a chairperson of Endocrinology Committee in 2011 and 13. She is presently the editor-in-chief of our Journal of Foxy, and she has more than 30 international and national index publication and author of more than 50 research papers at the international and national levels in different journals, and editor of 12 books. So I welcome Suvarna Khadilkar. Hello. Dr. Suvarna, will you say
hello
hi?
Everyone. Hello. Hi there.
Hi.
Good to be here with all of you.
Welcome,
Thank
Suvarna.
you, Niranjan, for the kind introduction.
Yeah. Now I request Dr. Komal Chavan to present the statistics of today. Dr. Komal Chavan, can we have the slides, please, of the statistics?
A very good afternoon, everybody. As we all know that the corona scare is all over India. We saw the nice picture about the Hyderabad city, which was 100 years back, and the statistics are changing daily. So these are the Indian statistics. When the lockdown was announced, that was day one on 25th of March. The first week, there were around 562 cases and 62 were cured and discharged with only 12 deaths. But as of today, active cases has risen up to 6,412 with cured discharge cases around 500 and deaths almost touching 200. And one patient has migrated. So the statistics have drastic increase in the cases in India. And we as a doctors are encountering, as a frontline workers, are on the forefront and have to manage a positive case of COVID or a suspect case. And so a lot of discussion has been done on COVID. And though our OPDs are shut now, we still have so many patients calling up for the common ailments which they are already facing before the COVID era. And they keep calling us, messaging us multiple times. So let us now use this lockdown period for academics and revisit the most commonest symptom or the complaint which comes in our OPD, that is the vaginal infections. And if this vaginal infection is not treated, and sometimes if not given the proper care at the right time, it can turn into a dreadful disease, persistent infection, to pelvic inflammatory disease, having a lot of complications later on. So, early diagnosis, better antibiotics are the key for management. And we have our stalwart speakers today, none other than Dr. Shanta Kumari, President elect FOXY 2021, and Dr. Swarna Khadilkar, Treasurer of FOXY and MOGS. A warm welcome to you both, madam. And I request to begin with today's proceeding with Dr. Shanta Kumari, madam's lecture. Over to you, madam.
Thank
Madam,
you,
please
Komal.
share your screen with the slides. Thank you.
Yeah. Thank you, Dr. Komal, for the lovely introduction. Good afternoon, friends. A warm welcome to today's webinar. As Komal has told, I think the past 1 month, all of us, irrespective whether we are a doctor or we are a policeman or an ordinary housewife, everybody is only talking about one thing, and that is the corona, the COVID-19. Friends, I think by the end of this month, I'm sure we'll be having a huge number of people in our country who will become PhDs in this infection. But well, we can have the general public to become PhDs in management of corona, but the end of the day, the people of India, the women of India will need us, the gynecologists, to actually deal with the day-to-day problem, which is the vaginal infections. And let's see what we can actually discuss about some perspective in the management of vaginal infections. I'm sure all of you can I not able can we have the slide yeah. So friends, what is vaginitis? It's nothing but an inflammation of vagina because of vaginal infections and PID. I'm sure that 50% to about 70% of our day-to-day gynecopedy revolves around PID, the acute clinical syndrome which is associated with the ascending spread of microorganisms which are unrelated to pregnancy or surgery, from the vagina or the cervix to the endometrium, the fallopian tubes. And friends, it is definitely an acute infection of the upper genital tract structures involving the uterus, tubes, and ovaries, often accompanied by involvement of the neighboring pelvic structures. By convention, PID is actually initiated by a sexually transmitted agent which ascends into the upper GI tract, distinguishing it from the pelvic infections caused by the transcervical medical procedure, pregnancy, and other abdominal processes that can extend to the pelvic organ. So friends, we all wonder how the vagina, which is exposed to the exterior, is able to prevent the routine infection. Friends, it is this Dodderlin's bacilli which acts like a mask. How mask is helping in corona. Dodderlin's bacilli is the mask which helps the vagina to be protected from getting infected, and that is like a policeman in the vagina. So friends, the normal vaginal microbial ecosystem, when the pH is altered, there's a restoration of the microbiota is very, very important. The common vaginal microbial ecosystems are all these Crispatus, the Gensini, etc. And other less common bacterial species which are found in the vagina include all these Atrobium vaginae, Gardnerella, etc. So friends, in a premenarchal girl, usually the vaginal pH is around 7. And as the girl grows up in the puberty, the pH comes down to 4. And in the reproductive age group, it is actually between 3.8 to 4.5. That's a normal reproductive age pH. And during pregnancy, we find that elevated vaginal pH is associated with the pregnancy is probably because of the increased volume of the mucus secretion. And as the woman ages and menopause sets in, we find pH again increases to 7 because of the decrease of the estrogen and progesterone level, which results in the decrease in the vaginal secretion. So friends, the loss of lactobacilli is actually linked to relatively high vaginal pH, more than 4.5, which can have associated overgrowth of bacteria, can lead to infections, the bacterial vaginosis, vaginal candidiasis, trichomoniasis, cervicitis, STD, cervical dysplasia. The adverse reproductive outcome, preterm labor, low birth weight, amniotic fluid infections, chorioamnitis, PROM, infertility, tubal infertility, etc. Friends, can we make a diagnosis based on the pH? When you look at the vaginal discharge, malodor, itching, and burning, when you have less than 4.5 pH, there is no odor, no itching, burning, it's a normal. When there is a thick, clumpy discharge and itching and burning, we think of candidiasis. With copious discharge, with malodor, think of bacterial vaginosis. Greenish discharge, with all the three, think of trichomoniasis. And when you look at the PID, we have got the statistics in US and India, in spite of us having 38,000 plus members in FOXY and equal number who are not so, still we don't have the accurate statistics. Today, everyone knows what are the statistics of COVID-19 in the country. What are the statistics in Maharashtra? What are the statistics in Telangana? But we don't have the statistics of PID. We do understand it accounts to more than 50% of the day-to-day gynec practice. And friends, infertility due to the PID occlusion, we find post-PID sequelae is the most common acquired infertility in women. And effect on fertility, yes. Laparoscopy for subfertility, when you go into one study, the pelvic pathology not clinically suspected were reported. And common pathologies identified in subfertile women was PID, 18%. And at the same time, we find that mild endometriosis also there. PID probability of the live birth, when you find the mild PID is about 90%, moderate PID 82%. And severe PID, there was 8-fold more likely to fail to achieve a live birth. Besides the dominant lactobacilli, we find that hormonal changes in the menstrual cycle, pregnancy, contraception, sexual activity also has an effect. And endocervical infection with STD can disrupt the cervical barrier. And clinical presentation may hence be at any point along from endometritis and salpingitis. We find that pain is the most common presenting symptoms. Pain, dull ache, and sometimes vaginal discharge, unanticipated bleeding also is seen. I used to think the patients are usually complaining of pain, and nothing is found. So most of the time, it could be like the women were actually trying to find a reason to move out of the house to actually get an outing. And we as gynecologists never understood that till today, when with the lockdown, we know what it is. And I think this is going to teach us to be more empathic to our patients when they come to us sometimes with not so important a problem. They can have fever in 30%. Don't think all the fevers are COVID-19. It could be PID, which is more common in our country. So CDC criteria, low abdominal pain, bilateral adnexal cervical motion tenderness. Additional criteria is oral temperature more, mucopurulent discharge, abundant WBC, elevated ESR and CRP, lab diagnosis of Neisseria, gonorrhea, chlamydia trachomatis, sometimes pelvic abscess, inflammatory complex. Specific criteria, TVS or MRI showing the thick and fluid filled tubes, Dopplers, endometrial biopsy, the lab findings consistent with PID. Now, PID, how are we going to treat? Parenteral treatment, regimen A, cefotitan 2 gram IV, and doxycycline 100 milligrams, and cefoxitan 2 gram IV and doxycycline 100 milligram per orally IV, 12th hourly, clindamycin 900 mg, and gentamicin, which is about 1.5 milligram per kg. Alternate regimen is ampicillin, sulbactam. Parenteral regimen for 24 hours after improvement, transition to oral regimens to complete the 14-day course. Oral treatment, ceftriaxone 250 milligram IV single dose, followed by doxycycline 100 milligram per orally or metronidazole 500 mg per orally BID for 14 days. The other regimen, cefoxitin 2 gram IV single dose with doxycycline 100 milligram orally or metronidazole 500 milligram BD. And regimen C, third generation cephalosporin IV and doxycycline, metronidazole. And again, the other treatment, because we can alternate with ofloxacin 400 milligram BD and clindamycin 450 milligram QID or metronidazole 500 milligram per orally. Alternative is azithromycin 1 gram per orally single dose. Conditions which need hospitalization, uncertain diagnosis, pregnancy, pelvic abscess, severe illness, failure to respond, inability to tolerate OPD, and failure to improve within 72 hours, and sometimes immunodeficiencies, HIV with low CD4 count. The PEACH trial were inpatient versus outpatient strategies. Mild to moderate PID in 831, meet follow-up, pregnancy rates inpatient 42%, outpatient 41%. There was no statistical difference in PID recurrence, chronic pain, or ectopic pregnancy rate. The OPD setting review at 72 hours, failure to improve suggests you need to further investigate parenteral therapy and or surgical intervention. Review at 4 weeks, compliance and clinical response to treatment, screening and treatment of the contacts. PID lab grading, mild PID, moderate PID, severe PIDs, pyosalpings. When you look at the MRI versus laparoscopy and ultrasound, PID confirmed 70% by lab, MRI concordant in 95%, USD in 80%. So only to diagnose, sometimes you need not do laparoscopy. Aggressive laparoscopy only consider for acute PID, to drain purulent, to lyse the bowel adhesions, and excise acute necrotic tubo-ovarian adhesions. Some of the pictures of the role of lap surgery, you can see how you can sometimes look at this Fitz-Hugh-Curtis syndrome, perihepatitis, where you can find this fine adhesions which are there. Tubal disease surgical treatment before IVF. Tubal disease has a detrimental effect on IVF, so you may have to treat it. So pelvic inflammatory disease, US guided aspiration of adnexal mass also has been advocated in some of the cases. Chlamydia trachomatis, there was a study where there was no history of abnormal pap smear, relatively high risk of chlamydia infection in those below 25 years. And you have to assess the titer of this chlamydia, and sometimes high titers may justify laparoscopy. To screen or treat before instrumentation was a billion-dollar question. Prophylactic antibiotics before instrumentation. Now the question is, do we need to do the COVID test for all the women in labor in the gynecology? I think taking proper precautions, universal precautions, is the way forward in the present circumstances. And now let's look at some of the new concepts in vaginal infection. Friends, we've got something, we always wish that we had some gloves where we can just put our 2 fingers and we have the diagnosis. In fact, these Ivanio gloves are very nice, where the index finger has an absorbing gauze and the thumb has the pH indicator. Can you hear me?
Yes, we can hear you, madam.
Yeah. So this absorbing pan on the index finger is used to collect the vaginal fluid, and the pH indicator on the thumb is the one which is going to change color and tell us how it is. So it's an easy way of diagnosing the pH. And this has been certified by Merck. And very simple, wash your hand, dry your hand, put your 2 fingers into the vagina, 1 finger, index finger, for a few seconds so that you have the secretion, take it out, and you immediately press together your forefinger and thumb so that they come in contact. And then when you open your fingers, you can check the color of the pH indicator, and lo and behold, you have the diagnosis. So, well, friends, once you've diagnosed, is antibiotics the cure? Sometimes I wonder, we used to actually think that we are taking too many antibiotics, and antibiotic resistance was a very big menace. The past 2 years, when we were actually doing a lot of conferences, one of the conferences, PIOG, we only discussed about infections, because we always thought that infections are going to be the new menace in the present generation. And lo and behold, we have seen that what an infection can do to the whole world. So friends, antibiotics may not be always the only treatment for anything. So we have to look at the other ways, how we can see that other than this antimicrobial therapy, how we can actually increase the resistance and the immunology. And probably we need to look at how the commensal lactobacilli in the vagina can be improved and how we can restore the vaginal ecosystem. So probiotics have played a big role to replenish the vaginal flora, to prevent or treat infections, and of course to prevent the recurrences. We got the oral probiotics and vaginal probiotics. The oral are actually, you have to use them more, and we're not very sure of how much is going to reach the vagina. So we have seen the effect of vaginal progesterone in our day-to-day practice. So probiotic bacteria directly into the vaginal administration may allow direct replacement of the probiotics so that can affect the vaginal microbiota and lesser time required for the vaginal health. So in this, we have got the pre and probiotic vaginal tablets, which can be used, which are composed of effervescent rapid release vaginal tablets. We have got some Ivanu, which has actually got all this Lactobacillus salivarius, the plantarum and the brevis. You need to understand they has to be stored in 2 to 8 degrees centigrade. So the direct and indirect antipathogenic mechanism of the lactobacilli include production of lactic acid and bacteriocins, lower the pH and kill the pathogens, form microcolonies that adhere to the epithelial cells and form a physical barrier against the pathogen adhesion and stimulates the host defense mechanism. Immunity, even today, everyone wants to improve the immunity of the body so that we can fight the corona. So I think we have to use how we can improve the immunity of the vagina to fight this PID. And all this plantarum salivarius and all adhesions, aggregation, all of them show that they are very, very active. So this vaginal pro and probiotic in the management of bacterial vaginosis, inhibition of the herpes simplex, it's a pro-fertility preserving form, and it acts at the arginine deaminase and activity against the chlamydia and trichomonas. So indication, prevention of common vaginal infections, bacterial vaginosis, aerobic vaginitis, vulvovaginal candidiasis, and trichomoniasis, and prevention of the recurrent UTIs to improve reproductive health. So friends, dosage 1 tablet intravaginally at bedtime for 8 days. Every month, preferably from 8th day of the cycle for 3 months. Directions, use at bedtime for 8 days. Tell the patient to wash their hands with soap, remove the tablet from the pack, do not break or crush the tablet. Insert the tablet, insert it inside the vagina with the middle finger while lying in a recumbent position. It's a very simple 1 tablet vaginally at bedtime for 8 days in pregnancy, followed by 8 days treatment every 4th week till the end of pregnancy. Even in infertility, 1 tab intravaginally at bedtime for 8 days, starting from 8 days before oocyte retrieval, followed by 1 tablet intravaginal at bedtime for 8 days, starting 1 day after embryo transfer. And if they are successful, the dose is scheduled as per a pregnancy. So evidence, when you look, there are lactobacilli containing vaginal probiotics to cure or prevent bacterial fungal vaginal disperses. There was a systematic review and recommendations where they have found that it was very effective. For bacterial vaginosis, there are a lot of these studies which have shown that the vaginal lactobacilli with the other supportive treatment was better where the recurrence was less. And all the studies have shown now vaginal probiotics for vulvovaginal candidiasis. There were some studies from Italy where lactobacilli vaginal tablet used actually helped in treating the acute vulvovaginal candidiasis. Lot of references which showed that the lactobacilli vaginal tablet was significantly better after 28 days of use. So vaginal probiotics in pregnancy, abnormal vaginal microbiota of bacterial infection during pregnancy. So probiotic supplementation during pregnancy might reduce the maternal and neonatal adverse outcomes. The normal vaginal flora, if it is affected, these probiotics can help in pregnancy. Again, the vaginal probiotic lactobacilli in infertility are found to be very useful, and a lot of studies have shown that they're effective. Even the vaginal probiotic lactobacilli has an effect on the sperm motility and viability. Studies have shown that these supplements are better in women who are taking the supplements and the better fertility rates. So friends, When you look at the PID, prevention strategies, primary prevention, prevent exposure and acquisition of chlamydial gonococcal infections, update knowledge about prevention, recognition, treatment of PID. I think we need to follow the COVID model and keep on talking to our women and men how to prevent the PID. And that will go a long way. Friends, we need to acknowledge our Professor Dr. Nozer Cherier and Dr. Bhupesh Diwan who have helped in this presentation. Well, science begets knowledge, opinion ignorance. We find that everyone is knowledgeable when it comes to the present day scenario, but PID is going to be the knowledge of only us gynecologists. So tomorrow only we are going to treat our patients, and let's make our Indian women PID free. Thank you, friends. Hello.
Hello, yeah, thank you, madam.
Awesome. Very nice. Dr. Shanta Kumari, it was awesome. We have got 1,400 viewers right now.
Very
in
good.
spite of coronavirus infiltrating the electricity lines of Rajasthan and Madhya Pradesh. Madam, you are still and you are now and you will be the Iron Lady. Coronavirus cannot enter the electricity grid when Iron Lady is sitting amongst us guarding Foxians and the healthcare workers. Very well explained. Dr. Komal, the mic is yours. Please ask one question and then we leave and go to Dr. Suvarna Khadilkar.
Yes, thank you. See, we have a lot many questions, almost 200 questions that I've been screening. But the one question which is very more significant, madam, you mentioned about the vaginal pH. So there is a question that should we routinely screen for vaginal pH in the patient who have history of prior preterm births?
See, there are some studies which have shown that by doing the vaginal pH and trying to correct it, the incidence of preterm birth can be reduced. There are some studies which have actually demonstrated that. That is why asymptomatic vaginal infection, we are always treating to reduce the incidence of preterm births.
So it would be a good suggestion to do. Yes. And that answers the second question also. What are the chances of vaginitis after preterm birth?
See, once you're having a preterm birth, then you suspect that you are there is some infection. I think try to treat the source of infection. If you treat that infection and with whatever is the, if need, the necessary antibiotic only, and then treat with pre and probiotic. These are supplements which are not going to increase the resistance or something, and that may lead to a better outcome in the next pregnancies.
Yes, thank you, madam. We'll take the next question after Dr. Suvarna Khadilkar's talk.
If I stop share, I can see you all. Is it? Yeah, yeah, I got it.
Yeah. Yes, over to you, Dr. Suvarna Khadilkar.
Okay.
Dr. Suvarna Khadilkar does not require any introduction, but to
share
introduce
screen.
She is also our Iron Lady of West India. So the electric current will not affect this transmission too. Welcome, madam. Sorry to interrupt you.
Share screen.
Is it seen now?
No, you have to
share screen.
I have done it.
You have to press it again and it will come.
Share screen. Okay, then what?
You press the share screen, you press down share. Green one. Green button arrow is there, see. Yes. Share screen.
You have to
I have done it, but it is not getting clicked.
Maybe you
you click it, don't worry.
Use with your iron finger.
Yes.
Yeah,
very
we got
good.
it.
Done.
And madam, we have got 1,500 audience now. So please present your whole presentation. People have joined while after the electric grid has collapsed, and now the Iron Lady of West India will be talking, so more will join. Welcome.
Okay, thank you so much, Niranjan. And I first, at the outset, I would like to thank all of you, Juventus, Niranjan, Komal, for having me here. It's wonderful to be connected here on Zoom with all of you. And I think most of the slides, am I audible?
Yes.
Yes. Please speak louder.
Most of my slides have been, I think, shared by Shanta, but I'll still take one more round because some of you might have joined a little later. So I'll be my focus would be on vaginitis or vaginal infection in pregnancy. How do I move the slides on? Okay.
Down.
So this is the protective vaginal ecosystem. As you can see, the vaginal ecosystem, the estrogen, the glycogen, lactic acid, and the pH between 3.8 to 4.2, which maintains the healthy vagina. All of us know the importance of vaginal pH and the lactic acid and lactobacilli. Um, when pH is altered, the restoration of microbiota is very, very important. And a normal vaginal microbial ecosystem is given here. The three important microbiota you can see, which are in bold: plantarum, brevis, and salivarius, are the most often dominating vaginal microflora. This is the changing pH physiology of vagina over lifetime. You can see at puberty, the vaginal pH is 4. When vaginal epithelium thickens and intracellular glycogen production begins, cervicovaginal secretions are produced and vaginal fluid becomes acidic. Then comes reproductive age, when there is a 92% of the lactobacillus species predominate in the vaginal flora and vaginal pH is acid. In pregnancy, the vaginal pH is 4. At menopause, the pH becomes 7, and I forgot the premenarchal phase when pH is also 7. So endogenous factors on physiology are estrogens, the cycle of menstruation, the pregnancy, and vaginal infections. The main factors that modify vaginal microbiota are the infections, that is aerobic vaginitis, bacterial vaginosis. Then the age, that is in childhood, there is low estrogen and glycogen levels, thin vaginal epithelium, and low lactobacillus, especially high pH. And I think, and the adult women, there is high estrogen and glycogen levels, thick vaginal epithelium. Postmenopausal, there is again low estrogen, glycogen levels, and thin disrupted vaginal epithelium. In pregnancy, there is lower concentration of mycoplasma and ureaplasma, decrease in pH, and increment in vaginal secretions, and other factors like ethnic group, smoking, and cancer. All these are going to affect and modify the vaginal microbiota. The loss of lactobacilli is linked to all this. The relatively high vaginal pH, that is more than 4.5, associated with overgrowth of bacteria, will lead to infections like bacterial vaginosis, vaginal candidiasis, trichomoniasis, cervicitis, STDs, and cervical dysplasias. Adverse reproductive outcomes like preterm labor, low birth weight, amniotic fluid infection, choriamnitis, PROM. Infertility like tubal infertility, ectopic pregnancy, pelvic inflammatory disease, and reduced sperm motility and viability. So all of us have understood what impact this high vaginal pH can have on women's health. Abnormal vaginal discharge, how do you define vaginitis? It is actually infection of vagina or inflammation of vagina, which leads to abnormal vaginal discharge, odor and irritation, itching and burning. It causes are infectious like vulvovaginal candidiasis. It is about 20 to 25% of women, they have this candidiasis. 40 to 50% of women would have bacterial vaginosis, whereas 10 to 15% of women would have trichomoniasis. And non-infectious type of vaginitis are like atrophic, irritant, allergic, inflammatory vaginitis. That is about 5% to 10% of all cases of vaginitis would be non-infectious. I have seen very bad vaginitis secondary to, the iodine which we used to use for painting the vagina. Many years back, it was an irritant, and I've seen such bad vaginitis that I always used to get scared to use, the paint vagina with iodine. But the newer products are much safer and they are associated with less of these irritant properties. Bacterial vaginitis, it is actually overgrowth of predominantly anaerobic organisms in vagina. That is Gardnerella vaginalis, Prevotella spp, Mycoplasma hominis, and so on and so forth, results in replacement of lactobacilli and an increase in vaginal pH. Recurrent vaginal vaginitis is vaginitis recurring within 3 to 4 months, within 3 to 4 years. I think that is, we have seen quite a few cases who come back again and again with infection. And this recurrent vaginitis really is very tough to manage, because they keep complaining, you have treated me, but still there is no effect. Bacterial vaginosis is associated with all this post-hysterectomy, vaginal cuff infection, post-abortal endometritis, increased risk of spontaneous miscarriage ranging from 13 to 24 weeks, and preterm birth, increased risk of acquiring STI, especially genital herpes and HIV. Vaginal trichomoniasis is associated with adverse pregnancy outcome, premature rupture of membranes and preterm delivery, and low birth weight. These are the various signs and symptoms of various types of vaginitis. The bacterial vaginosis is generally giving fishy odor. I think all these things are very well known to most of the gynecologists, but I'll just give a brief review of all these symptoms. The fishy odor, thin and off-white homogeneous discharge that may worsen after intercourse, and pelvic discomfort may be present. There is no overall signs of inflammation, and there are other risks like increased risk of HIV, gonorrhea, chlamydia, and all. Vulvovaginal candidiasis, the organism is candida albicans. The symptoms are white, thick, cheesy, or curdy discharge, vulvar itching or burning, no odor, pruritus, or dysuria. Vulvar erythema and edema is present. Trichomoniasis, all of us know, it gives rise to green or yellow frothy discharge, foul odor, vaginal pain and soreness, copious malodorous yellow-green discharge, pruritus vagina. And as we all know that when the vaginitis or vaginal discharge is accompanied by pruritus, these are the two major causes. That one is candidiasis and second is trichomoniasis. Atrophic vaginitis is thin, clear discharge, vaginal dryness is present, there is dyspareunia, and there is mild itching. Now, this is usually due to inflammation, so that it is evident on examination. You can see that the vagina is very thin and friable. The irritant or allergic vaginitis, that is a contact irritation or allergic reaction to any chemical or non-infectious agent. So burning or soreness is present, vulval erythema is there, and inflammatory vaginitis like possibly autoimmune, could be purulent vaginal discharge, burning, vaginal atrophy, and inflammation. So what are the risk factors which contribute to vaginitis? I think specifically during pregnancy, if you see, pregnancy itself is one condition where there would be increased candidal discharge because of relatively low immunity. But if there is otherwise in other patients, bacterial vaginosis is predisposed by low socioeconomic status, vaginal douching, smoking, use of an intrauterine contraceptive device, multiple sex partners, unprotected sexual intercourse, homosexual relationships, frequent use of higher dose of spermicide nonoxynol 9. Trichomoniasis is predisposed by again all those factors: multiple sexual partners, lifetime frequency of sexual activity other than sexual transmitted infections, lack of barrier contraceptive use, illicit drug, smoking. Vulvovaginal candidiasis is predisposed by the systemic antibiotic or vaginal antibiotic use, diet high in refined sugars, uncontrolled diabetes mellitus is a significant and rampant predisposing factor. Atrophic vaginitis is usually seen in postmenopausal women. Other conditions associated with estrogen deficiency, post-oophorectomy, and chemotherapy, immuno immunological disorders, premature ovarian failure, endocrine disorders, and anti-estrogen medications. Contact dermatitis like soaps, tampons, contraceptive devices. So friends, when you see a patient of vaginitis, here is a list of various predisposing and risk factors which you must rule out on history, whether they have come across or they have all these factors in the history or examination. The diagnosis is usually clinical at the beginning with physical examination, clinical signs like back to all the three types of vaginitis have slightly different examination findings, and you can many a times clinically diagnose that yes, this is vulvovaginal candidiasis, this is trichomoniasis, and this is perhaps bacterial vaginosis, because usually normal appearance of tissues, discolored discharge with little abnormal odor and homogeneous discharge that adheres to vaginal walls. Now, laboratory tests like vaginal pH is recommended, which is found elevated in bacterial vaginosis, which is found normal in candidiasis, and which is high in trichomoniasis again. Microscopic examination and wet mount and KOH preparation of vaginal discharge would give typical clue cells in bacterial vaginosis, and the pseudohyphae and mycelial tangles in vulvovaginal candidiasis, and motile trichomonad, many polymorph nuclear cells in trichomonial infection. WIP test is seen normal, there is no odor, then positive, there is bacterial vaginosis, negative candidiasis, and may or may not be positive in trichomoniasis. Additional tests like AMSIL criteria, 3 or 4 criteria must be met with, and the criteria, Nugent's criteria, are also described for bacterial vaginosis. Then for candidiasis, the KOH microscopy grand stain culture is recommended, and in trichomoniasis, DNA probe test sensitivity of 90%, culture sensitivity of 98%. But I feel in practice, all this we do not routinely conduct, only in exceptional resistant cases which are not responding to your routine line of treatment. Maybe all this could be there. Otherwise, we kind of give syndromic management, or if you have the diagnosis is staring at you, you give that specific treatment. So these are the various criteria. Then pH-based diagnostic. I think this is already been covered by Dr. Shanta very well, but these are the normal vaginal pH between 3.8 to 4.5, and an altered vaginal pH is one of the symptoms of vaginal infection. You can see the range from 3.5 to 6, and if vaginal discharge less than 4.5 malodor, this is an altered vaginal pH, is definitely indicative of vaginal infection. In healthy vaginal ecosystem, pH is 3.8 to 4.5, candida pH less than 4.5, bacterial vaginosis more than 4.5, and trichomoniasis again pH is more than 4.5. These are the excellent the gloves to even gloves to test for the pH of vagina. They are very beautifully equipped, and they have the chemical put on the thumb side, and the index finger collects the vaginal absorbing gauze, so that during pregnancy, if you try to test, the chemical will not irritate the amniotic membranes or the cervix or the pregnant, introduce irritation inside the pregnant uterus. So already this is certified by Merck. This is the technique of use of this glove, which can routinely help you identify if there is a high pH. You will be alerted, yes, there is some infection, and if you treat this infection on time, you will prevent preterm labor or adverse pregnancy outcome. Assessment of vaginal discharge is very nicely given in this slide. First, the history, then you assess the risk, the predisposing factors, Then the examination will give you a hint as to what are you looking at, what is your probable diagnosis, and then you will come to a conclusion as to what kind of treatment you are going to offer. So the differential diagnosis of possible would be vaginal infection, and again the three infections like bacterial vaginosis, candidiasis, and trichomoniasis. So this is a rather busy slide, so I will not be able to go through this, but this is a general algorithm for diagnosis of vaginitis. And when you are diagnosing, when you are taking things for granted that it's a simple infection, at the same time you have to look into the severe kind of complicated infections where once in a way you may come across any kind of ulceration, fistulas, any foreign body. See, these rare occurrences you may come across, which could be the cause of abdominal vaginal discharge. So the appropriate diagnosis and specific treatment should be initiated. So how do you go about managing vaginal infections? Vaginitis, the primary regimen for treatment of bacterial vaginosis could be oral metronidazole 400 milligram 3 times a day for 7 days. The cure rate is up to 95%. After 4 weeks, declines to 80%. A single dose of metronidazole 20 gram was recommended, but no, it is not recommended. Vaginal preparations like 0.75% metronidazole gel, 2% clindamycin cream, and 100 milligram of once a day clindamycin ovules, they all help in controlling vaginitis. Now, the indications for therapy of candida: symptomatic women found to have candida on either microscopy or culture, asymptomatic women who do not require treatment, and asymptomatic male partners do not require treatment. Indications for therapy of trichomoniasis is in fact a positive test for trichomoniasis. Regardless of symptoms, you must go ahead and treat, and if there are specific classical examination findings, you can go ahead and treat, but here you must treat the sexual partners. The vulvovaginal candidiasis, in uncomplicated cases, short course of antifungal oral and topical preparations would be sufficient. Complicated cases would require intensive longer course of antifungals. Vaginal tablets containing lactobacilli can cure bacterial vaginosis and reduce vaginal inflammatory response. I have found these probiotic or lactobacilli containing vaginal tablets more useful when patients come in recurrent vaginitis, and there is a frustrating feeling the patient gets. That time, if you use this, I'm sure the episodes of recurrent vaginitis would certainly reduce significantly. Lactobacilli vaginal pessaries establish normal vaginal flora. For non-responders, vaginal antifungal and antibiotic therapy may be required. These are the percentage of sensitivity of aerobic vaginal isolates to various antibiotics. So you can see amoxicillin against all those organisms. You can see amoxicillin, combination of clavulanic acid, cefoperoxone, and sulbactam. These are all 100% effective and sensitive for these organisms. These are the various treatment regimens for most common causes of vaginitis. I think we have already discussed the commonest regime that we usually follow, and the alternative regimens could be tinidazole, clindamycin, various combinations in different high doses and for longer time. And during pregnancy, metronidazole 400 milligram orally thrice daily for 7 days will be useful. And if there is a recurrence, the first recurrence, retrial of the same regimen or trial of alternative initial regimen like multiple recurrences, metronidazole of 0.75% gel intravaginally twice weekly for 4 to 6 months. Treatment of sexual partners is a routine treatment of sex partners, is not recommended especially for bacterial vaginosis. For vulvovaginal candidiasis, also treatment of a sex partner is routinely not recommended unless he has any specific infection or the symptoms or signs of the same. So this is the topical azole therapy or fluconazole 150 milligram orally single dose. Topical azole therapy applied intravaginally for 7 days to achieve the mycologic cure. Topical azole therapy for 7 to 14 days or fluconazole 150 milligram orally every third day for 3 doses is used for maintenance. You tell me when my time is up because the slides are pretty good in number. So this is oral fluconazole 100 milligram 150 or 200 milligram weekly for 6 months. This is for trichomoniasis. I think we already discussed. And metronidazole 2 gram orally single dose in any stage of pregnancy can be used. Now this is the treatment recommendations, various. I think I will not go into the details of this. The treatment recommendation for vaginal dryness, I think I'll rather go to the slides of pregnancy. So the role of probiotics has already been discussed by Shanta. The antimicrobial therapy is generally effective, but there is high recurrence. So probiotic with selected lactobacillus strains is effective strategy for prevention of infection. And this is the dose of lactobacillus acidophilus, lactobacillus rhamnosus is given here 10 CFU per day for 2 months. Post-antibiotic probiotic use, vaginally administered probiotic for bacterial vaginosis and vaginitis is effective. Intravaginal administration of lactobacillus for 6 to 12 days or oral administration of acidophilus or ramosus GR1 and fermentum RC14 for 2 months resulted in the cure of bacterial vaginosis. So I think this wonderful slide has already been discussed by Shanta, and it is not always that antibiotics are the final answer. If they fail, they may have, they may wash out the commensals. So it is important to use probiotics. So post-antibiotic probiotic use is also recommended, and it will reduce the vaginal inflammatory response. This is the mechanism of action of EVA-NEW tablets, and I think this is the only vaginal route of probiotics available. Direct and indirect antipathogenic mechanisms of lactobacilli include production of lactic acid and bacteriocins, lower the pH and kill the pathogens, form microcolonies that adhere to the epithelial cell receptors and form a physical barrier against pathogen adhesions, and stimulation of host defense mechanisms against the pathogens. So these are the EVA-NEW stain characteristics. You can see all the 3 properties like production of H2O2, adhesion, CO, aggregation, all of 3 bacilli is fairly good. These are this is the composition of the vaginal probiotic, that is L. salivarius FV2, L. plantarum FV9, and brevis CD2. It should be stored at 2 to 8 degrees. Do not freeze. These are the indications of usage. In concerning with pregnancy, the sole important indication would be prevention of preterm birth and improve the fertilization chances, prevention of recurrent UTIs, and of course prevention of common recurrent vaginal infections of all the 3 types. So in pregnancy, what is the recommended dose? 1 tablet intravaginally at bedtime for 8 days, followed by 8 days treatment every 4th week till the end of pregnancy. That is what is the recommendation. So what is vaginal probiotics in pregnancy? What is the rationale of using this? Abnormal vaginal microbiota or bacterial infection during pregnancy. They alter the acquisition of neonatal flora, promoting preterm delivery. Pathogenic bacteria in amniotic fluid activate the innate immune response, and production of PGs increase uterine contractility. Greater possibility of preterm delivery, development of neonatal infections, sepsis, and necrotizing enterocolitis. And probiotic supplementation during pregnancy might reduce maternal and neonatal adverse outcomes. So these are the, this is one study where normal vaginal flora disorders and application of probiotics in pregnancy shows total 60 patients they had studied, and they found that during pregnancy with non-treated patients, they found that the vaginal administration of lactobacilli is effective, preventing the development of abnormal vaginal microflora, lowering the vaginal pH and lowering the presenting part of the fetus, modifying the cervical parameters to preterm delivery. I think that's about it regarding pregnancy. I think this slide has also been discussed by Shanta, and I think we come to an end. So in all, I think I like this concept of giving probiotics so that we prevent recurrent infections, especially all those women who are prone for recurrent infections. And I think it's a good option. And even though tablets as well as those gloves are really a novel introduction to our clinical practice, which will help us in day-to-day uh, clinics.
Thank you very much, Dr. Suvarna Khadilkar. There are a lot of questions. The questions are running into pages. But may I ask you a very common question which a medical student has asked? Are there any chances of yeast infection after taking oral contraceptives?
Actually, no. Oral contraceptive also contains estrogen. So it is less likely that you will have more of yeast infection. But it depends on the composition of the tablet that you are taking. And in general, we have not found that in fact it will make the vaginal health better.
Thank you. Also, there is one more question. During this lockdown days, everybody is more concerned about our practice. There is a patient, somebody is having a patient of recurrent vaginitis, recurrent infections. So should we, how much we can postpone pap smear in such patients?
Pap smear, I think in the presence of active infection, one should not go ahead with the pap smear. So once you give a course of antifungal or whatever the specific organism they have found, after that antibiotic is given and the local treatment is over, you call the patient after about 8 days, you review whether the infection has been controlled or no. And if the active infection is not present, then you could do the pap smear. But make sure that you do not do for vaginal examination. You must just do a gentle PS, and if you find there is no infection, then you take a pap smear in the same sitting.
Yeah, but we can postpone that pap smear by a month or so.
You can postpone, but there is every chance that she will come back with another bout of infection, because these women who have recurrent vaginitis, they are known to come back again and again at the end, interval of say 3 to 6 weeks or so. So she may come back again with infection, then again you treat, and again you examine after about 8 days of treating the infection.
Thank you very much. Yes, Dr. Niranjan Chavan.
Wow, what a wonderful presentation by both the iron ladies guarding the electric grids all over India. But just on a lighter vein, we have crossed more than 1,600 members, users online, and we have more than 300 questions. And I appreciate the efforts you both senior members have done. Today we are locked down, our delegates are sitting at home, and you require a round of applause. Well, we can't hear that, but the efforts of you both and other Foxy senior members who have taken to come online, and it's feeling like a real conference conclave where we are sitting and looking at things. So there are questions. I will try to take as much as possible. And I request now Dr. Shanta Kumari Madam to please come online. There is a question from Ahmedabad. It's basically the role of diet in treatment of vaginal infections and the use of probiotics. Dr. Suvarna has already told that probiotics can be used. Your take on that from Dr. Ami Mehta. She has asked this question to Dr. Shanta.
What is it? Repeat the question. Hello?
Yes, madam, we can hear you. What is the role of probiotics in such cases of vaginal infections?
Yeah. Yeah, we have actually, I have mentioned, and even Suvarna has reiterated. See, we find that vaginal infections are very common.
Take your mic near the face so that it is audible. I request same with
Can you hear me?
Yes.
Yeah. I think, see, when you are trying to treat the vaginal infections, the basic concept should be you try to restore the vaginal microbiota back to the normal. So in such situations, to bring the microbiota or the vaginal pH back to normal, I think the pre and probiotics are going to help us so that, recurrent infections can be prevented. Otherwise, we use some local antibiotic, some oral antibiotic. It's going to be only short term. And repeated infections you want to prevent, you have to increase the immunity of the mucous membrane.
Oh, so nicely explained. And obviously, we can give doses of this also. Can I have a question to Dr. Suvarna? Hi. Yeah, we just stopped the screen sharing and therefore we could not see Dr. Shanta, but now we will come back to her. Dr. Suvarna, madam, what is the role of painting the vagina with betadine? Obviously, we are aware, but then in certain circumstances, when you have a repeated vaginitis, would you recommend that to the patient?
No, I don't think you can tell the patient to do that, because we do it as a in patient treatment for pre-operative preparation or something. And betadine is good enough. Betadine, I have not come across very bad irritant vaginitis, but we should not tell the patient to do it at home. I think it should be done in indoor patients.
Suvarna madam, this is for
Niranjan,
you.
I have one comment. Even though we are physically locked down, we are not mentally locked down. We are academically very, very proactive, and we are continuously in touch. I will say there is a epidemic or pandemic of COVID, but there is a bigger pandemic of webinars. Everybody is doing webinars, and so much of exchange of knowledge is happening. I think we are going to utilize this time to our fullest. Thank you so much for organizing this.
Thank you for your encouragement, and I appreciate such encouragements from everyone. And India being a free country and there is democracy, everyone is free here, so that they are doing their academics at home apart from the household chores. Today I posted a picture of doing dishwashing on Facebook. I have not gone there and seen, but surely it will make a lot of difference, and really we should help our partners in this situation. And thank you both of you to join. There are many questions I would like to ask. Is repeated vaginitis related to seasons? Dr. Suvarna.
Actually, I have not found it to related to seasons, but in general, it is seen more often in summer. That I can agree. But however, I don't think it is scientific reason for seeing it more in any particular season.
Okay, this was the question by Dr. Alka Chandrasekhar. Now I go to Dr. Geeta Malik. Well, she has already asked the question. Dr. Preeti Sharma from Lucknow. She wants to ask you, Dr. Shanta Kumari, does Evanew tablet help in treating severe fungal vulvovaginitis in post-hysterectomy diabetic patients?
Yes. See, we have to understand that we need to improve the microflora of the vaginal tissue. So especially in the menopause, we know the pH is altered. Menopause is a time because of hormonal deficiency, and be it a surgical menopause or a natural menopause, the tissue pH is affected. Definitely this pre and probiotics will help the tissue to regenerate and renew itself and reduce the incidence of this recurrent vulvovaginitis.
Dr. Shanta, we have our colleague from Ahmedabad, Dr. Neeta Vinit Mishra. Dr.
Okay, hi Neeta.
Partner, yeah, and his wife. She has asked a question: would you prefer to have local gel preparation or some energy-based device as treatment for recurrent pelvic infections? Dr. Neeta Vinit Mishra.
See that we are now discussing the role of pre and probiotics for the local vaginal infections. Definitely, we are now, this particular tablets are those which are inserted into the vagina to improve the absorption. Maybe Neeta is looking at further down. We may have some instruments which may like vibrate or something, which may increase the absorption of these lactobacilli into the vaginal tissue. Maybe in the lockdown period is the time to actually think about these also. Why not? Neeta, you can go ahead and try
Okay.
to
One
invent
more
something.
question. Yeah. Dr. Suvarna, this is from Dr. Nanita Chandra. In the first and second trimester, what are the oral antifungal drugs and doses can be prescribed safely with potent effects? Your take on this?
Can you just repeat the question? I'm sorry, I missed it.
In the first and second trimester, what are the oral antifungal drugs which are safe, and what are the doses with potent effects? A generalized summary of certain drugs in first and second trimester which can be given, antifungal drugs which can be given in pregnancy.
Okay, I think we have one slide full of all those medications, so I can pass on that slide to you if you are interested, or I can tell the organizers. There is a big list, but in general, first trimester you should avoid any systemic antifungal. So if there is a severe infection, you could use the local antifungal rather than systemic. And after second trimester, whichever are, as per the schedule of the drug, whichever are the safe drugs, you could use them. I will send you the slide. There are quite a detailed chart we have made for that, so I can send you all on that particular issue.
Okay. Dr. Smita Sarang has asked, now in this lockdown period, the patient has got a resistant vaginal infection and she complains of pruritus, itching. She has already taken multiple courses of doxycycline, metronidazole, itraconazole, vaginal pessaries, probiotics. Here there is no mention of exactly what is her age, but the symptoms are still persisting. Now what more to do in this lockdown period?
I think just tell her to go ahead and do the vaginal gel and cream, try it again. But then she has tried everything, prebiotic, probiotic, antifungal, everything. So in this scenario,
it's tried probiotics.
No, that's what she told. She has tried.
Right, probiotics.
So basically, she has tried everything under the
sun. Let her only stop thinking about the vaginal infection and put her brain into the other activities at home, the lockdown. Yeah. So keep herself busy.
Make her husband,
so that, yeah.
has to make her husband more work.
So that will actually take her brain off.
One more question. Now, Dr. Suvarna, from this is what is VIP test? Please explain, Dr. Dinesh Prajapati.
I'm sorry, I don't know myself what it is. I'm very sorry. I got this just now, and I'm not a diagnostician, so I won't be able to enlighten you more that. But there is something to do with the, we have to. The smell of on putting that reagent, the smell comes and you have to identify. If you know, Komal, you can tell.
Yeah, it is basically a slide test where you take on a slide a drop of the vaginal secretion and mix it with a KOH.
Dr. Komal, take your phone
and you put potassium hydroxide on it, and it emits a fishy odor. And because of the amine metabolites of the vaginal secretion, and it is a diagnostic test of bacterial vaginosis.
Okay. We are just waiting for some few questions, but I can tell you, madam, from Andhra, Telangana, Bhavanara, which means hope for all, with Iron Lady being with us, all colleagues are seeing you from your state. And it's really gone to 1600, and I am not joking. It's a fact. So thank you, madam.
I think I have to tell you, I was not a very diehard fan of webinars. It is Niranjan who has actually goaded me and made me agree to the webinar. And I enjoyed your webinars because I think we are so used to seeing each other. So I'm missing all the interaction. Every week we used to see each other.
Obviously, so, madam, when we are in a conference in a 5-star hotel where we have a podium and a moderator standing there and panelist, I don't think any one of us will talk the way we are talking now in the real.
I know.
Desh janna chahta hai. देश जानना चाहता है क्या है. Actually, lockdown has created a lot of issues, and
but
where we are trying.
Niranjan, let me tell you something. I
Yes.
think we shouldn't be so negative. I think this is a once in a lifetime opportunity for
Madam,
all of
Mike,
us.
please take the mic near. Thank you.
I think this is a once in a lifetime opportunity.
Absolutely.
When would any of us have got one solid month to actually sit at home, only go out for emergencies? So you really utilize this time properly, I think. And I think most of the gynecologists are doing it. Be it revamping their cupboards, or be it revamping their cooking skills, or just trying to recuperate. Maybe you need time to rejuvenate in your own home. So I think maybe this is the right time. So let's enjoy it and let's not get worried. But what is happening is, unfortunately, we are all having that negative issues. Please don't worry. I'm sure we have seen a lot of infections come and go, and there's nothing which is always permanent. There's always a change. So this will also change to better time.
Madam, there are few questions. There is one question from Dr. Arpita Gandhi from Ahmedabad. Dear esteemed seniors, I am very happy to see you. But I want to ask, there is one patient who has been complaining of vaginal redness, itching, especially in the immediate pre-menstrual 2 to 3 days time. And rest of the month, she is asymptomatic. Kindly opine regarding the management of such a case.
See, there are two issues. One thing is there are cyclical changes because of the change of the hormonal content. Some women may have more in the premenstrual, or some women in the late menstrual cycle, and so probably, or if she's a young girl or an elderly girl, age. We don't know the age.
Yes,
so
she is not written the age there.
Pre and probiotic is very useful in these particular sect of mostly, usually it's the girls, but sometimes we find even some of the girls or young women with endometriosis and PID, they have an increased symptoms during the premenstrual cycle. So we'll have to actually look into that also.
So madam, would you recommend the use of vaginal washes like Lactacid? I don't want to take anybody's name, but there are other products which are available in the market, and also in pregnancy can be used. Dr. Shreya, thank you. And if used, what is the frequency? See, what is the frequency of using such lactic acid medications which are there?
Ideally, actually, too much of washes is also not advisable. Only when there's repeated infections, maybe you need to use this, because what happens is, when you keep on using these, the pH of the otherwise normal epithelium will again get affected. So depending, they can take a short course, maybe when during the intense cycle, use it for about 2 to 6 weeks, because we don't have evidence-based studies. So you have to use for 8 weeks or 12 weeks. So I think it varies with the experience. What do you think, Swarna?
I think I agree with you. But there are, girls who almost take this Lactacid every day.
No.
I have to really every time counsel them and tell them there is no need for doing that every day, because they're extremely, careful about their personal hygiene. So they're using it, but it is not at all necessary and not recommended as a routine. But if you think that there are certain cycles in perimenstrual phase when the pads are there and your vulval hygiene is difficult to maintain, or if you think there has been some irritation, infection during that phase, you could use that as a special case. But I don't think it is required to use in all the time every day. And there are some companies who have made 3 or 4 types of such washes. When in presence of active infection, this Lactacid and normal, which are physiological, should not be used. If there is infection, there are special washes which are available, you should advise them to use. And there are less infection, there are different phases, like postmenopausal women should use different washes. There are menarchal young girls should use different types of washes. So there are different types also, but Lactacid is the most physiological ones, which there is no need for using when you are not infected. There is no need. or you should, and when you use it after infection, where the infection has to be controlled, and then you can use these physiological preparations.
Okay, we will take the last question now. Dr. Malhotra from Agra, relation of diabetes and vaginitis. Dr. Suvarna Khadikar, you look at me, madam.
Which, no, which I'm reading the message. Which remedies?
Madam, relation of diabetes and vaginitis.
Oh, there is, I mean, I have nothing to say. It is more edges, since we are well aware of this association. It is the diabetes which, attracts all types of infection. Likewise, it will also attract vaginitis. So there is nothing
Okay.
so special about it. In general, diabetes will attract infections of all types, and it is the candidal infection which is more common in presence of diabetes.
Okay. Now, Dr. Shanta, madam,
Yeah.
this is a very important question. This will be the last question because it is a very important in lockdown period. What are all the infections that warrant emergency? I am repeating, emergency in this COVID-29 situation.
COVID-19.
As an obstetrician, gynecologist.
What is an emergency is a very, very individualized point. See, some patient may think a vaginal itching is a big emergency. Some patient who may be having extreme, an obstetric patient who may have some decreased fetal movements, he may not perceive it as an emergency. That depends on the knowledge of the patient. And of course, that's where the knowledge of the obstetrician also counts. So I think in the present scenario, what is advisable is on the telephone contact, please talk to your patients. Not like before I used to get, we would have got irritated sometimes when we get a call from the patient. But there's one person whom I always remember when I am talking to a patient. That is Nozer, whenever he's talking to a patient, he's extremely sweet. So I used to ask him, how is it, Nozer, that you can take all the questions with a smile on your face? And he's, what he has told? I think, Shanta, only men understand women's problem. I said, but no, sir, I think women do understand the problems which women patients have, and we even understand how men handle them. So I think we have to talk to our patients and we have to decide based on our clinical knowledge, which is an emergency, which is not. But
so thank you both of you. Thank you both of you. It is a wonderful presentation which you did and we all enjoyed. I request Dr. Komal Chavan to give and summarize with salient points, because after we close, people still want to see and the link is on, but it gets expired, and after 2 days still people want to see, and then they ask me, please summarize the points. So I request you, that is your domain, please go ahead.
Yes. Okay, so we had an excellent talk today by Dr. Shanta Kumari on PID and Dr. Suvarna Khadilkar on vaginal infection in pregnancy. The talk basically focused upon from the normal vaginal ecosystem to normal physiological discharge to a pathological discharge, and the most pathological discharge which is seen, that is bacterial vaginosis, vulvovaginal candidiasis, trichomoniasis, the pH difference in all the discharge, how to diagnose them. There was also talk on the newer modalities, pH gloves to detect pH and to categorize the different types of discharge, wherein the pH difference would be, pH changes would be there, and that would specifically tell us which discharge are we dealing with. Then it also, we discussed in detail about the treatment, about the metronidazole treatment in bacterial vaginosis, then the fluconozoles, which are contraindicated in the pregnancy, which was said by Dr. Suvarna Khadilkar madam, and the other consequences about PIDs, and in detail, and also we spoke in detail about probiotics, which are the more in thing in pregnancy, and the types of probiotic, and also the vaginal route, which is more better and which is more effective than the oral route. So, and we also answered a lot of questions. How do we practice and treat vaginal infection in this COVID era? And I think a lot of doubts have been solved. And it was an excellent presentation by both of you have done full justice, because treating a vaginal infection sitting at home is very difficult for all obstetricians. We always want to see, because seeing is believing, and now we want to hear and we want to talk to patients. So I feel very nicely summed up by both of you. Thank you, madam. Shanta madam wants to say something.
Yeah. Komal, I think we really have to congratulate one chap, that is Niranjan Chavan, for his proactive webinarization of this lockdown period. And I think, and we have to appreciate the Science Integra, Subbu, Seshan, Meenal. They have been working 24/7. Great guys. I think after the lockdown, they need a break.
Yes.
So
definitely their Science Integra team are doing a wonderful job. It is a very nice platform, and they are making the full use of lockdown to provide academics to all. So this is
so well
giving
done.
academics, yes. And I would like to thank, yes, Dr. Niranjan.
I also join with Shanta in
Yes.
thanking everybody, the Niranjan, Komal, the Science Integra team, Juventus, everybody. They all have done well.
And I think, Suvarna, the most important are the delegates who are viewing the link.
Absolutely.
Imagine, I really appreciate them, because, in spite of, I know how much work will be there when you are at home now. So in spite of it, they're able to log in.
They have become more busy now, sitting at home.
I know. I'm very happy I'm not in homemaker. I'm only a gynecologist.
So I'm very happy that all of us are laughing and happy rather than having anxiety and depression in this lockdown period.
Yes.
And we are all busy doing something or the other apart from grooming, dishwashing, drying clothes, and preparing food.
And eating.
So Niranjan, any tips for us?
So thank you.
Madam, we had a wonderful laughing time and we had a wonderful time. I'm getting messages regarding you people talking so nicely. And kal fir isi samay fir milenge. Tomorrow we have recommendations and guidelines for pregnancy in COVID. So take care. Ghari raha, स्वस्थ रहा, मजेत रहा, घरमा रहो, मजामा रहो, અને સ્વસ્થ રહો. Thank you so much.
Thank you.
Bye.
Thank you.